Hello, my name is Rebel Stallings. I'm the Senior VP of Physician Services and Corporate Medical Officer of PruittHealth. Today's presentation will be on COVID-19 and seasonal influenza. I do want to preface with a disclaimer that information presented in this presentation is only as current as September 30th, 2020. While we are experiencing this pandemic and understanding that COVID-19 is a new virus, we do have some historical experience to draw upon and allows us to make some hypotheses and some preparation as we head into the influenza season. Our last influenza pandemic caused by H1N1 began in the spring of 2009. And basically from April 12th to April 10th, 2010, the CDC estimated that there were over 60 million cases of influenza A H1N1. There were also more than 12,000 deaths in the U.S. and over 250,000 hospitalizations. And despite its inclusion into the influenza vaccine since 2010, H1N1 continues to circulate annually. This strain has been monitored and documented, but given the use of influenza vaccine, we have been able to contain H1N1. This is somewhat in contrast to the last human coronavirus epidemic, SARS, which we were able to abate because of aggressive containment procedures before a vaccine could be deployed. So we have not seen community transmissions of SARS since 2004. So let's review our current experience. Based on our current cases of COVID-19, the resurgence of cases during our summer months, and now again a slight blip in increased cases during the fall, and the anticipated vaccine development timelines, it is quite clear to us currently that we will not see an abrupt termination of COVID-19 like we saw with SARS. Rather, it's likely that we will continue to have community transmission of COVID-19 well into our influenza season and potentially adjoining with a potential influenza epidemic. The healthcare community is well aware that we will be dealing with co-infections with both influenza and COVID-19, as well as patients having either of the viruses alone. COVID-19 really kind of first came onto the world stage, I guess we could say, in China in late 2019, with the first confirmed case here in the U.S. in January of 2020. Since that time, there has been, per the Johns Hopkins Coronavirus Resource Center, more than 34 million cases worldwide, with over 7 million cases in the U.S. between January and September 30th, 2020. Based on data from the World Health Organization, flu has about 1 billion cases worldwide each year. And last year, the CDC estimates that there were between 39 million and 56 million cases of the flu here in the U.S. Our current knowledge of morbidity and mortality as it relates to influenza and COVID-19 is still being understood on the breadth and depth of it. However, we do have some current numbers of deaths related to COVID-19. Worldwide, there has been over 1 million deaths related to COVID-19. And in the U.S., there have been over 200,000 individuals who have died secondary to COVID-19 between January 2020 and September 30th, 2020. These numbers are from the Johns Hopkins COVID Resource Center. And we know from the World Health Organization that the mortality related to flu estimates that between nearly 300,000 to 650,000 individuals die each year from flu-related causes. We can see from these numbers that COVID has a huge impact as it relates to mortality. We also know that not all ages are affected equally, either with both COVID and influenza. Those individuals older than the age of 65, those individuals with comorbid conditions, those individuals with a relative immunocompromised immune system will have higher rates of mortality associated with both COVID and influenza. While the similarities between influenza and COVID-19 are definitely related to how they are transmitted, respiratory droplets, smaller virus particles from someone that is considered infectious or sick, they could be asymptomatic and still be infectious, or actually exhibiting symptoms, be the COVID or influenza, can transmit the virus to other persons within a certain, considered nearby. That's why we have social distancing, particularly in COVID. Yes, there can be some transmission, although it does not seem to be of any significance, great significance, related to people touching surfaces and having the virus on those surfaces and then transmitting that virus either through their mouth, touching their face, eyes, nose, and so forth. There was a lot of data when COVID first came out about how long does COVID live on cardboard, metal, wood, plastic surfaces, and as such. Really the focus is hand washing, social distancing, face mask wearing. Those things to continue to reduce transmission by close contact and respiratory droplets when talking, singing, coughing, sneezing, and also decrease the transmission from surfaces. That's why we're saying wash hands, socially distance, those types of things. Symptoms are very, very similar as well. We know that fever, cough, shortness of breath, body aches, all of those are very similar in both COVID and influenza. Symptoms such as nausea, vomiting, diarrhea tend to be more in children, probably in both subsets of COVID and influenza. And so we're still learning more about COVID symptoms. The routine symptoms that we started looking at in January, which was primarily respiratory based, has moved to muscle fatigue, muscle aches, generalized fatigue, loss of taste, loss of smell. Those are expanding, non-specific, vague symptoms. Both can result in pneumonia. Both flu and COVID can have mild cases to severe cases requiring hospitalization and intubation, and even as we stated earlier, fatality can also be an end result of both infections. Similarities of influenza and COVID-19 as it relates to treating the virus begins to diverge a little bit. Now, where the similarities still are is that both are viruses, and therefore treating them specifically with antibiotics is not recommended, nor would it be effective. We do sometimes add antibiotic treatment when individuals with either influenza or COVID-19 are found to have an associated pneumonia. Primary treatment is that of addressing the symptoms, reducing the fever, supplemental oxygen for hypoxia, and so forth. Now, where we start seeing a divergence is that we do have FDA-approved medication for the treatment of influenza to decrease the progression of symptoms, to decrease the severity of symptoms, and actually can be a chemoprophylaxis to abate an outbreak, particularly like in a long-term care setting. We don't have that same arsenal when it comes to COVID-19. There are a number of medications that are being investigated that are part of a study. There are medications that have been given EUA, FDA authorization, emergency use authorization. The majority of those medications require being enrolled in a study, require being admitted at an inpatient level of care, if not even an ICU level of care. So again, this is where we start seeing the divergence of the similarity, because we definitely have FDA-approved treatment when it comes to influenza. We're still looking for studying, even though we do have some emergency use authorized FDA-approved treatments currently for COVID. Most requiring hospitalization. Where we start seeing a significant difference between influenza and COVID-19 is how they can present. We talked about some of the symptoms that are very similar, the respiratory symptoms, some that are very different, being some nonspecific and vague, and we really want to go over those a little bit more now. But foundationally, where the difference starts is that COVID-19 can present as an asymptomatic infection. 40 to 60% of those infected with COVID-19 may present as asymptomatic, but still be able to transmit, thus still infectious enough to make other people sick with the coronavirus. We talked about these wide range of nonspecific, vague symptoms. So maybe not so many are asymptomatic as they are pre-symptomatic, parasymptomatic. They have just fatigue, loss of taste or smell, acute loss. That is sometimes difficult to really understand, because as our aging population, it has been shown that a good portion of them may have already altered taste. So their ability to understand if that's worse, how significant that is, we might not be able to really gather that information. As stated earlier, maybe some symptoms are more likely to happen in kids than adults. Again, just being very, very nonspecific, fatigue, muscle pain, achy. I've had patients state they just don't feel like themselves. Again, most of the time, the flu is classic. I have fever, body ache, chills, sore throat, respiratory symptoms. And you're able to definitively say, oh, that's the flu. Now we have COVID that can present exactly like that, or it can present with absolutely no symptoms at all. Again, where the difference is and the difficulty of understanding who may be co-infected with both influenza and COVID-19. This is just to reiterate what we had spoke of earlier about treatment for COVID and influenza. Early in the pandemic, hydroxychloroquine was touted as a potential medication that could be used to treat COVID-19. We did not have any data to look at, or extensive data, I should say, to look at the use of hydroxychloroquine in COVID-19, but it appeared to be promising. It was given an emergency use authorization from the FDA, and at the same time, studies utilizing hydroxychloroquine with or without azithromycin, with or without other medications, began, and soon we learned that there was no significant difference in end outcome of mortality with the use of hydroxychloroquine, and there may be an increased risk of morbidity, mortality due to the side effects of that medication. Again, most of those studies were done in the hospital, not in an outpatient setting, not in a long-term care setting. We still have a number of medications that are going through that have received EUA from the FDA, emergency use authorization from the FDA, and are waiting to see if there will be other medications that can be used, either oral, outpatient basis that doesn't require intensive monitoring, either cardiac or laboratory-wise, that could be used in a community setting, that could be used safely in a long-term care setting. Again, we talked about oral antiviral medications that we already use, Tamiflu and such, for influenza, and we continue to use that. So more to come as we continue to get the data surrounding medications to be used in COVID-19. Now I want to talk about the difference when it comes to vaccines. We know that there is currently no vaccine available in the U.S. And I have a little asterisk there. In the U.S., we're still in the development mode and the testing mode, phase 3 for a number of vaccines. We do know that the Research Institute of Moscow released a Sputnik V, formerly known as GAM-COVID vaccine that the Ministry of Health of Russia Federation released in August 11. That did draw some scrutiny from, I think, the international healthcare platforms, just given that it was felt the appropriate testing, validation of this vaccine had not really gone through the rigors that most of kind of worldwide health, particularly World Health Organization, would be looking for. We in the U.S. are under kind of this Operation Warp Speed, not kind of, we have initiated this collaboration with several U.S. federal government agencies as well as private sector, biopharma firms, to really work in concert to get a COVID vaccine out and available to the Americans as quickly as possible. As it relates to the flu vaccine, of course, we have several flu vaccines available and will be available this year. There is definitely a push to get individuals immunized with influenza this flu season. I kind of wanted to circle back on Operation Warp Speed because its primary goal is to produce and deliver 300 million dosages of safe and effective COVID-19 vaccine by January 2021. We know that the 18 or so pharmaceutical CEOs and leadership signed a safety pledge in early September 2020. They wanted to reassure the American people that even though they're on this accelerated development, manufacturing, and distribution, that safety would not be curtailed during this entire process. This process is put in place so that we can get a rapidly available, low-cost countermeasures to immunize the American population, particularly those at risk, but truly everyone, so that we can protect particularly those at risk for getting coronavirus. Again, I want to reiterate We know that we will not abate coronavirus with just the vaccine itself. What we are trying to do is decrease as much as we can the number of cases. Same thing with the flu vaccine, decrease the number of cases. We also know from historical perspective, those that are immunized tend to have, if they do get the virus, because they have generated some immune response, will have a less severe disease. There tends to be decreased morbidity and mortality with those that receive the vaccine. And so there are a number of endpoints that we have to look at that we can still benefit from both individuals receiving the flu vaccine as well as the COVID-19 vaccine. We do understand that there can be complications related to both COVID-19 and influenza. The morbidity associated with both of these viruses can be long-standing and long-term in their damage to end organs such as lungs, heart, kidney, and the brain as it relates to COVID-19. We are still learning some of the sequelae secondary to both severe infection and those that may have had relatively mild disease, but still several weeks or months later complain of fatigue, muscle weakness. For influenza, we know that the virus itself can cause a kind of myocarditis or inflammation of the heart and brains and muscles, and can also be involved in some multi-organ failure. So both of these have significant morbidity outside of the known mortality associated acutely with being infected with either influenza or COVID-19. So what can we expect? I believe it was a New York Times editor or writer that came up with the word twindemic. So what should we expect? What have we seen as it relates to influenza and COVID-19? You know, COVID-19 really happened at the end of our influenza season, and because we quickly had shelter in place and some lockdown of jobs and movement except for essential workers in the March and April time frame, we did not really see a combination of COVID and influenza, one as a co-infection or one causing confusion with diagnosing of the other. We have seen that we are now opening up states, opening up visitations. How will that impact now as we move into the influenza? I want to start with what we know as it relates to the benefit of flu vaccination. The CDC has compiled data related to the benefit of flu vaccination in the 2018-2019 flu season. Approximately 49% of the U.S. population chose to get a flu vaccine during that 2018-2019 flu season, and it is estimated that it prevented 4.4 million flu illnesses, nearly 6,000 flu hospitalization, and 3,500 flu deaths. And that's just 49% of the population choosing to get flu. The real initiative over the next couple of months is to have greater than 75% of the population, eligible population, to get the flu vaccine. If we're able to decrease those illnesses, those hospitalization, the impact, the positive impact of not overutilizing and stressing our healthcare resources will be significant. And we saw what happened in March and April and the beginning of May when our resources were really overwhelmed with individuals coming to the hospital with COVID, with individuals requiring intubation, and we're not having enough ventilators for those patients. Our healthcare providers themselves, doctors, nurses, technicians, and all of the support staff from dietary, environmental, those individuals themselves becoming ill, and therefore the infrastructure as a whole was massively strained. So being able to truly mitigate that we know that flu vaccines work to not only decrease flu illnesses, but these other endpoints, hospitalization, death, resource utilizations. This helps us to know that moving forward in this 2021 flu season, that this is a strategy that we need to address. Speaking about the decline of influenza activity, as I noted earlier, and this is just a graph noting in the U.S., where we saw fewer people left home because of sheltering in place. We saw fewer people seeking medical care because of sheltering in place, maybe fear of going to the hospital. There was a push for social distancing, hand washing, and mask wearing that definitely happened right at the end of our influenza season. And because of that, we did not see an upsurge of influenza activity towards the end of our 1920 flu season. Here again is more of a visual representation of looking at influenza surveillance, particularly in the southern hemisphere, in our more temperate zones, where influenza activity remained very low in comparison to previous influenza seasons. And we do believe that's because there were mask mandates. There were significant sheltering in place, closing of borders, and the institution of influenza vaccines. So all of those kind of social distancing, mask wearing, sheltering in place, and influenza vaccine mandate really has, translated into a significantly low, record low of influenza seasonal infections. We learned in late September that Emory University School of Medicine in Atlanta had studied the response of 40 individuals over the age of 56 with the Moderna vaccine for COVID, and found that it produced high levels of antibodies against the coronavirus. This is particularly exciting because, again, one of our most prominent at-risk group is those over the age of 65. And while most of the vaccines require 2 dosages, at least 21 to 28 days apart, as does Moderna, it is encouraging that we see older individuals that receive this vaccine having a very positive response. This is actually published in the New England Journal of Medicine, and looking forward to more data related to these vaccines as we move through phase 3. So looking at historical data, we know that co-circulation can occur. We also know that the significance of that can be mitigated. We know from monitoring COVID over the last 9 months what are the signs and symptoms that can make it very difficult to distinguish between influenza and COVID-19. What is unknown is truly the frequency and the severity of co-infection. Unfortunately, as COVID entered the U.S. at the end of our flu season, we had implemented lockdown, face masking, shelter in place, social distancing, and that's been very, very good in lowering the co-infection. But now that we have less regulatory mandates for sheltering in place, we are opening up non-essential businesses. We don't really know what the frequency and severity is going to be with co-infection with influenza and COVID-19. And then we will have to deal on the clinical stage, the complexity of treating both COVID-19 and influenza. We understand the use of steroids may be not the best treatment when someone also has influenza. How will some of the antiviral medications work with some of the FDA, EUA therapies in the hospital? I know we're looking at a number of studies to try to glean that information. So that's still some of the unknown as it relates to the potential co-infection and co-circulation of influenza and COVID-19. While we think about areas for mitigation, we know that we have to continue the effort of vaccination, particularly influenza vaccination as we get into the influenza season, and really looking at those groups, older adults, those with comorbid conditions, those that are immunocompromised, and those of minority groups, African American, Latino Americans, Native Americans, that seem to be hit harder during this pandemic. Adhere to face masks, social distancing, hand washing, and formalizing consistent clinical management algorithms, so that we are all addressing this in some evidence-based manner, even though the evidence is very, very short-lived, only over the last 9 months when it comes to COVID-19. And lastly, we cannot underestimate the impact of social determinants of health and how we need to focus on those to mitigate severity in the upcoming respiratory viral season with influenza and COVID. As we stated, we know that it definitely hits certain minority groups greater, ethnic minority groups greater. How do we, not only in our healthcare management, our government initiatives, and our federal mandates, move forward to address lack of access, lack of testing in certain areas, populations, zip codes, persons, adequate nutrition through this. We are learning about different vitamin deficiencies and generalized health that really has a direct impact on not only our chronic conditions, but how that interplays with when there is a superseded infection with COVID-19 and or influenza, and economic inequalities that happen, particularly with those that are considered essential workers, loss of job, loss of housing, and all of those social determinant impacts to outcomes. Now that's probably an entirely additional presentation, but as we work through mitigating the risk of this pandemic, we have to take those things into consideration as well. Thank you so much for spending these few minutes with me going over some known, some unknown, and yet developing data as it relates to COVID-19 and influenza. I hope that you were able to take a few points away, something that you didn't know, something that was reinforced, and that this helps with your risk mitigation and management of individuals with COVID and influenza in the coming months. Thank you.